Everybody, my name is Alex Pond with the UNM Division of Community Behavioral Health. Welcome to today's webinar presentation for Rural and Community Psychiatric Residency Program webinar series. A couple of announcements before we get started. Please make sure your sound is muted during the presentation. If you have any questions, please submit them in the chat or feel free to unmute if Dr. Tai opens the floor. For those requesting CE or certificate of completion, we'll share an evaluation link at the end of the presentation. To receive the certificate, you must attend the entire presentation. And now I will hand it over to Megan. Thank you.
Thank you, Alex. Hi, everyone. My name is Megan Shedd. I am a resident psychiatrist here in the Department of Psychiatry and the Rural Chief. And I want to introduce our speaker today. It should be a really interesting talk. So thank everyone for coming. Her name is Dr. Jessica Tai. She's a second-year psychiatry resident here in the Department of Psychiatry at University of New Mexico. Her clinical interests are in transitional age youth, college student population, and eating disorders. And today she's going to give a great discussion on self-injury and suicidal ideation. So I'll turn it over to her.
All righty, thank you for that introduction, Megan. So Megan already went over a little bit about me, and Alex already went over a little bit about continuing education credits. I have no financial disclosures to disclose. And I just have to read that the views expressed in this presentation are those of the speaker and don't necessarily represent UNM. So our learning objectives for today are to assess patients for self-injury and suicidal ideation, to determine individualized patients' risks for self-injury and suicidal ideation, and to interpret self-injury and suicidal ideation cases and formulate responses to them. So we're going to have two cases at the end that I will get to. So what is the definition of self-injury in the context of what we are going to discuss today? Self-injury is intentional self-infliction by cutting, burning, or otherwise wounding of the skin without necessarily the intention of death. This can include things like in the definition above, such as cutting, which might be what we primarily think of when we instinctively or reflexively think about self-injury, but it can also include other forms of self-harm, such as hair pulling, hitting or punching the self, skin picking with the intention of hurting oneself, or head banging. I just wanted to highlight that, hitting or punching oneself or head banging is something that is commonly seen in the populations who suffer from intellectual disability. So that is also a significant form of self-injury that one may not necessarily reflexively think of. Sometimes it's often done alone and in secret, and it can be hard to assess at these times the incidence because it's very underreported, and you may have to go out of your way to ask an adolescent or an adult about these behaviors if you don't see any overt signs, especially if it's not cutting and you don't necessarily see scars. And sometimes self-harm is viewed by outsiders as an attention-seeking behavior by patients or adolescents or children. But oftentimes, as discussed in the bullet above, self-harm is not even mentioned to anyone. So what are some signs of self-injury? As we briefly mentioned in the last slide, if there's cuts or scars on arms or other body parts, it's always prudent to ask about those. How did those result? I think sometimes we often think of self-injury signs or scars as, horizontal scars or marks on forearms, but sometimes patients will cut in a different looking way, such as one single longitudinal scar that might not look like what we typically think. So it's always important to ask. Alternatively, sometimes patients will show up in the middle of the Albuquerque summer when it's 95 degrees and they're wearing, long sleeves or tight jeans, and it seems kind of off. So it's always important to ask at that time. And if they do say that they do self-injure, I ask about how they did. And if it is something that's inflicting the skin, I ask them if they would be willing to roll up their arms or even their pant legs. Alternatively, some patients will point out to you immediately after they disclose that they have self-injured, that they have these scars, and those ones are a little easier to identify. And other signs that someone might be injuring themselves is expressing explicit suicidal ideation, which we'll get to in this talk as well, being irritable or having a depressed mood. So always important to ask, just to point out, and because it can be a risk for suicidal attempts, as we'll talk about later in this presentation. So why do people self-harm? Is it solely because it's an expression of their suicidal ideation? Sometimes that is a reason that people do self-injure, but a lot of people that you ask, why do you self-injure? They don't necessarily say it's because they have suicidal ideation. So it's always important to ask why they are doing it or what feelings they're experiencing, as we'll discuss later. There's a lot of linkage between current trauma that they're experiencing or a history of trauma, particularly childhood physical abuse or childhood sexual abuse. By self-harming, it can be a way to dissociate from emotions. Self-injury can reduce emotions that are hard to release, such as aggression, irritability, and anxiety, even more than depression sometimes. This physical pain can distract from the stressors and be a way for them to express their emotions if they don't have a social support or someone that they can talk to. It can also be a way of control if they feel like with trauma or a history of trauma or otherwise that they don't have control in their life. And in the case of adolescents especially, it can be something that they see on TV or social media and they're imitating their peers. It can also be very addicting. There is an off-label use of the medication naltrexone, which you guys may be aware of, that we use for alcohol addiction. And you can use it off-label for not enjoying other pleasurable activities as much, such as cutting. It's been used for gambling, but it just goes to show that, you know, self-harming can be as addictive as some of these other behaviors like substance use and gambling as well, if we're going to use naltrexone for it, even though it is an off-label use. And we talked about if you want to express emotion, if you don't have social support. And also sometimes when I ask patients about it, they say that they're punishing themselves. They feel like they deserve it. So always important to ask the reasons why and the emotions so that we can assess where we need to go from there in terms of risk assessment. So why is it important? As I alluded to in the last slide, people who self-injure do not necessarily want to die or commit suicide. There is a higher risk of suicide in the long run. And by the ADAPT study, self-injury was a 10 times greater predictor of future suicide attempt than a previous suicide attempt. And the greatest predictor of future self-injury was past self-injury. And even if it doesn't lead to a suicide attempt, self-harm can inadvertently lead to serious injuries. Patients can need to get sutures. It can cause infection. So it's always important to address. So that's going to segue us into talking a little bit about suicide, and we'll also go back to self-harm as well. So this graph is for suicide rates in the total United States from 1999 to 2014. And as we can see, 2014 is the lighter green, the darker green is 1999, and the rates of suicide went up in almost every single population except 75 and over and females. I actually read recent data that the suicide demographic rates have shifted a little bit. In the past, we had been taught a lot that it was the younger population, but now the leading population in the US is the 45 to 64 age range, which I'll show a graph for the males as well. So it's that middle age, and after the middle age, it's actually the 65 and older population. So a little bit of a shift. And I will get into it. This graph It was for 1999 to 2014. If you look at the most recent data, every year suicide rates from 1999 up until 2018 slowly increase. And then in 2019, there was a little bit of a drop. I think the drop was actually like 1% or 2%, a slight drop, but very reassuring nonetheless. And then actually in the pandemic, they actually found in the recent data that the rates dropped again. So that is reassuring. The overall trend over recent years has been an increase, but there has been some drop recently. And yes, so I'm looking at my notes and it said that it declined from 14.2 per 100,000 in 2018 to 13.9 in 2019. So a slight drop, but still reassuring. And, obviously it's hard to know why the rates dropped during the pandemic with a lot of stressors that might have been going on. Some theories that I read were that, cyberbullying or bullying in general is a stressor for kids. And with kids not being in school, that might have contributed to a slight drop, or that the stressors experienced by the pandemic were something that felt like the entire United States or world were experiencing. So it was more of a, we're all in this together feeling. But nonetheless, nice to know that at least in recent years, they've dropped a bit. And then this is the suicide graph for males as well. So yeah, you can definitely see here why maybe they said the second highest population now is that 65 and up population, as you can see in the males. So I talked a little bit about kids just there and bullying and reasons for suicide. And I wanted to bring up reasons that child mental health rates are on the rise, and that the American Academy of Child and Adolescent Psychiatry described that children's mental health is now a national emergency because self-injurious behavior is so prevalent in kids, and the rates of suicide and mental health crises in kids is alarming. So this is a series on Netflix called 13 Reasons Why. There was actually a child psychiatrist at Pittsburgh, Sancy Jacobson. She wrote an op-ed that went viral on 13 Reasons Why. 13 Reasons Why the show is just not a good portrayal of suicide, and that ACAP was not supporting the show. ACAP being the American Academy of Child and Adolescent Psychiatry, and why they thought it could potentially increase rates of suicide attempts or ideation in kids. So the protagonist in the film basically commits suicide, and the show follows the aftermath of it, the other characters reflecting on what she did, why she did it, and it really romanticizes self-injury and suicide. And it's very graphic. It shows some graphic scenes of her self-injuring. It shows inadequate school intervention by counselors and adults she tried to reach out to, no one really giving her help. And most of all, it portrays that the protagonist's only choice was suicide, and it really glamorizes what she did. And it could influence kids to think that if they committed suicide, that they may be revered in the aftermath and not the consequences of what else could happen. So that's just something that is a portrayal of suicide in the media, and potentially why children's mental health is such a crisis right now. So I've briefly talked about the epidemiology above with the graphs, but here's some more data in written form on suicide rates. Suicide rates increased by 33% from, that should say 1999 to 2018. I apologize because of that correction, with 2019 dropping a bit, but markedly increased, and then a slight drop off as I discussed before. It's the second highest cause of mortality for that young age group from 10 to 34, and I believe the leading cause is accidental death. And it's the fourth highest cause of mortality for ages 35 to 44, and fifth for the age group of 45 to 54. And we have to take into account that in the older age groups, there may be other health-related reasons that would cause for higher leading causes of mortality. More than 90% of individuals who attempt suicide do not go on to die, but may suffer lifelong sequelae, whether that's mental health reasons or physical health reasons from their attempts. And 47,500 individuals successfully committed suicide in 2019. As I discussed before, suicide is the second leading cause of death from 15 to 29-year-olds. So what are some of the most common lethal suicide methods? Firearms, which I think is very relevant in the United States and in New Mexico. That is the most lethal method. It's hard to come back if you have a gun to your head, unfortunately. Suffocation is number 2, and poisoning is actually number 3, which I thought was interesting. I think we get a lot of patients who say they overdose, but if they don't necessarily use the right amount or the right type of medication, it could just lead to that lifelong sequelae like I talked about before. So it's important to ask about suicidal ideation, which we'll get into, and self-harm. So that way we can address, is this something that would lead or put them at a lot of high risk for suicide in the future? Or is it a way to dissociate, to control, to express emotion or anger, as I talked about before? So what are those questions that you should ask when you are suspecting self-harm? So usually, I think a good way to ask is just to ask initially if you have ever self-harmed before. And how did they do so? What method? Because it's important, if they are still doing it, to try to safety plan with the family to maybe restrict sharps. I ask where they harm themselves on their body, because it can be easier to identify if it's on their arms, but if it's something like a tight leg or their upper thigh and they're just wearing jeans, it could be hard to look at. Did you use any items to harm yourself? Like I discussed before, safety planning with family to lock those items up or remove sharps from the home. How often have you done this? It's different if it's an adolescent who just did it last week, or if it's an adult who's like, I did it once when I was younger and I've never done it since. When's the last time you did this? Kind of following the statement above. Have you used any other methods in the past? Have you told anyone about this? I think this is important for adolescents and children as well, especially if you're going to talk to the parent afterwards and there's some uprising because no one knew about it and now this is the first time they're hearing. Or was this, or has it ever been an attempt to take your life or kill yourself? Really asking about the emotion they feel when they're self-harming. So this is a chart I got from SAMHSA, and I like it. I think you guys will get the slides for this, but it shows the intention of high risk, basically some of the questions I asked before, but if you use more than 3 methods, they consider that high risk. If obviously you are injuring your genitals or face, those are just high risk locations because they're sensitive areas. If they've ever had to get hospitalized, needing sutures or something, the emotion they feel, how many times they've done it, if it's greater than 10, that's also high risk, and how often they do it. Sometimes you get patients who do it every day or multiple times per week versus that patient who's done it once a couple years ago and never done it since. So that leads us to just using self-injury and self-harm as an overall risk assessment for suicide. Always asking if there's a history of self-injury. I cited the DAP study earlier saying that it was a predictor of future suicide attempts. If there was a close contact suicide attempt or history of completion, I always ask, even if there was an attempt, I think that's one of the most important parts of the family history when we're gathering and interviewing, because patients may try to imitate, and this goes for not just blood relatives. This could be a loved one, a partner, a distant uncle or aunt, basically anyone that they consider close. If they bring it up, like I had an Uncle Bob who attempted suicide, I always follow up and ask, how did they attempt suicide? Just keeping in the back of my mind that patients may try to attempt that method if it was someone they knew, and I documented it in the chart for future providers as well. I look at the extent of the scars because sometimes patients aren't the best historians. A lot of times kids will say, I don't know. And you can tell from the scars if it's recent, something that obviously happened, in the last couple weeks. If there's presence of suicidal ideation, which I will bring up later in the presentation, a history of suicide attempts, and a history of psych hospitalization, because it's especially high risk if they were hospitalized in the last 12 months or the last 30 days. So when assessing for suicidal ideation, I think it's important to bring it up in the conversation. They've shown that asking about it does not necessarily, make someone think about doing it if they've never thought about it. Sometimes after asking about depressive or anxious symptoms, or if patients have discuss a lot of their stressors, I say, that sounds like a lot. Does it ever make you think that sometimes you would just go to sleep and never wake up, as a segue into it? Or I say that sometimes patients tell me they wish they just didn't exist anymore. And I try to normalize it so that way the patients feel like others are also discussing it too, so they don't feel ostracized or like they're someone that's abnormal. I always ask about the frequency of the ideation, such as how long it lasts, the last time they felt this way. If they've been saying it's been going on for the last 2 months, I ask, has it been every day? Is it once a week? And the severity of it. And I follow up with an assessment for intent, such as, do you ever think you would act on this? Have you ever acted on this in the past? And then if they have, I ask when it was, what they did, and how it was stopped, since they are obviously here with me today and it wasn't a completed suicide. I ask about the impulsivity of their past attempts, like if it was premeditated or if it was something that they did very impulsively in the context of stressors. For example, if a patient tells me that they overdosed, I always ask them, was it your pills or was it someone else's pills in the house? I think that taking pills in the house is less premeditated than if someone were to physically go out to the store, buy a pill they think is lethal. That shows a little more intent. There is more time for them to go out, do that, and still have the suicidal ideation be severe enough that they want to go through with the act. Similarly, I asked them how they took the pills. If they take pills one by one, that shows a lot more of severe suicidal ideation than just impulsively taking a handful of pills, because a handful of pills, they could just take it in half a second and then regret what they did perhaps, versus, if you're going to take one pill at a time for 100 pills, that takes a significant amount of time. And if we learn that they just impulsively took a bunch of pills, that could help us safety plan in the future, for example, giving their meds in bubble packs where all the meds are individually packaged one by one. So it takes them longer to take them in the future if they have a potential to overdose, and potentially someone intervening or them reaching out for help midway through. I also assess their intent by asking if they've practiced, if they do have a plan on how they would commit suicide, such as if they put a gun to their head, if they've bought a noose, if they formed a noose, if they've, gone to a bridge or something, if they say they have thoughts of jumping off something, and assessing for preparatory behaviors, such as writing suicide notes, giving away things that shows that they're preparing, which is also a scary thing that we need to follow up on. So some tools to help assess for suicide. We've heard of the Columbia Suicide Severity Rating Scale. There's actually 4 versions of this. There's the lifetime since last visit, the screener, and the risk assessment. There's a lot of different forms. There's ones that are tailored to specific populations, such as the pediatric population, those who are cognitively impaired. There's a military veteran version. And there's also a screener version with 5 questions, which is good for emergency rooms, other healthcare providers outside of psychiatry, schools, and first responders. And it can help quantify suicidal ideation for research studies or trials, or also to help psychiatric providers once they get into their room. So I'm just going to go into this briefly. So this is the one that's the screener one, and number 1 and 2 are screening questions on if there's any thoughts of suicidal ideation, if there's non-specific active suicidal thoughts, such as have you had any thoughts of killing yourself, not necessarily asking about a plan, but if 1 or 2 are yes, then we need to go into 3, 4, and 5. Which assesses for active suicidal ideation with any methods and with intent or not intent. Any yes on this already scores for suicidal ideation. If it scores for a 4 or 5, it could be higher risk, and just something to consider if there needs to be further evaluation or care. And these things are really quick. They're great for even people who aren't mental health clinicians. It needs no formal training, and it can take literally seconds to ask. The Columbia scale is like 4 parts, so I just screenshotted 4 of them. So that way, because they couldn't fit all on one slide, this is the intensity of the ideation, questions like how many times have you had these thoughts, asking about that frequency, how long do they ask, and then also intent is assessed with the controllability and deterrence, like if you think that there's any protective factors. This is for suicidal behavior. I just wanted to point out here, I think it's also important to ask, which this helps as well assess, if you've had an attempt in the past. They ask about it, obviously, in the first part. And then in the following questions, they ask what happened to make it not succeed. It wasn't interrupted, as in you pulled a gun that you thought there was a bullet in and it just didn't go off, because that's still a very lethal attempt that thankfully did not go through for other reasons. Or was it aborted by yourself, such as you decided to stop yourself for some reason because you changed your mind? Or was it someone else intervening, finding you before it would happen? So good to assess as well. And then this just assesses for the lethality, what interventions happened if they were hospitalized. So what are some warning signs for suicidal ideation and attempts? Isolating from peers and family, increased depression, anxiety, irritability, and mood, increased substance use, because that can also lead to impulsivity, among other reasons. Poor coping skills makes it harder for patients to deal with stressors that do come up. Maybe patients are complaining that their psychiatric medications aren't working. That can be a sign in the weeks leading up. Sometimes patients won't necessarily complain, but family members maybe recognize significant changes in sleeping and eating, and that can be either an increase or a decrease. In the youth, you can notice academic decline or loss of interest in hanging out with friends or hobbies or extracurriculars, and a preoccupation with death or dying. So just a reminder, this is like the sad person's mnemonic for suicide risks. The sex, male is higher risk, age less than 19 or greater than 45, as I discussed in those first graphics with the epidemiology of suicide in the US. Depression or hopelessness, that scores a 2. P is for previous attempts or psychiatric care. And I'll bring that down to if it was a serious attempt in the past, that's also 2 points. Excessive alcohol or drug use, as I discussed before about the substances, rational thinking loss, separated, divorced, or widowed, that also kind of goes along with no social support, and stated future attempt. So you can just see where that would necessarily score on low, medium, or high. Some other risks is if a patient has chronic pain or comorbidities. That goes for medical illnesses such as cancer, chronic pain. These can be things that are really hard to deal with for patients, and acute stressors or chronic stressors. Recent loss of a loved one, just the mere access of firearms or having firearms in a household is an increased risk for a suicide attempt. a recent diagnosis of a psychiatric illness, a recent discharge from a psychiatric hospital. We discussed before 12 months or 1 month. Some important cultural considerations for New Mexico. The Native American population has been found to have a 50% greater risk of suicide attempts compared to the general population. So that is for the entire US, but just because our Native American population is so large here in New Mexico, just something to be cognizant of. And Caucasian is also a risk as well. A history of aggression or impulsivity, a history of abuse, as we discussed before, the LGBT population, recent acute psychosocial stressors, divorce, unemployment, legal troubles, which is why the coping skills we talked about earlier is so important, and just some cultural considerations that there may be a lower mental health utilization by some minority groups or groups that don't necessarily have the greatest perception of mental health, maybe a stigma against mental health until things are possibly too late. So on the flip side, what are some protective factors? Good coping skills, as I talked about, resiliency, religious or moral beliefs against suicide, having young children in the home, being future oriented, and having access to healthcare. So how can we safety plan with families and loved ones to limit medication access or lock them up? It's a good idea to tell families or loved ones if they have a history of overdosing or serious suicidal ideation about overdosing on meds, to maybe lock up the medications, administer one at a time as the patient needs that day, and watching them take them to make sure they're not stockpiling or cheeking. Removing firearms and sharps or locking those up as well, gun safes and locks. Opening bedroom doors for adolescents and children for increased supervision, possibly even if necessary, removing the doors from the hinges, and return precautions and providing crises hotlines. After I've gone over this, I had a couple cases I wanted to bring up. So in this case, a mother calls APD reporting that her 13-year-old daughter has locked herself in her room, threatening to kill herself. She has a knife with her. She has a previous psychiatric history of depression, but no prior hospitalizations, no guns or weapons at home, but household sharps are indeed present. So how would you act in this case? What would you assess for? And do you need to involve anyone else? And how would you advise mom? Are there any thoughts, or otherwise I can discuss? Okay, I just wanted to point out that when constructing this case, I made the age 13 for a very specific reason. At the age of 14 in New Mexico, it varies, but a 14-year-old has consent to medical treatment. So in this case, I think it would be important to ask the patient about her reasons for why she is threatening to kill herself, if it's something that's acute, the frequency and intent, like we talked about before, if this was an acute stressor that had happened, or if it was something that was ongoing. Adolescents can be very impulsive, but it's always important to take all factors and do a thorough examination, asking how long it was going on. Was this just a fight with mom, or was this something that has been ongoing from, stressors? Sometimes I found that parents may report, oh, this was just something acute that happened the last couple of days. We haven't been getting along. And then when you ask the adolescent patient, there's just been long time stressors that have been building and making them want to have suicidal attempts. I would also ask, even though they're 13, about if there were any substances involved, because we talked about the impulsivity. And when bringing her in, she's 13 in this case. So ultimately, mom still has consent. But if it was a 14-year-old child, I always ask the patient, I let them know that they have consent. and I asked them, would you like to be hospitalized? I just want to know your opinion. I explained that they have consent. And obviously, as with all patients, if it's deemed necessary, we can still put them on an involuntary hold. And if necessary, I can explain that. But just, trying to develop therapeutic alliance and rapport, because this is possibly this patient's first interaction with the mental health system. We don't want to ruin it from the get-go, but just telling her about consent if she was 14. But in this case, she's 13, so mom would have the consent for that case. Also, I would let mom know about what was going on and assess if there's a need for CYFD to be involved, if there were any stressors that the 13-year-old reported that were concerning that needed child protective services. So this case is a little bit longer, but 40-year-old female living alone after recently separating from her husband in the last year after she found out he had gambled away their savings and their debts were in both of their names. She was admitted to UNM hospital for an intentional overdose of 30 of her oxycodone tablets in combination with drinking a bottle of wine. She also has chronic back pain from falling off a ladder decades ago that required 3 surgeries, which is why she has oxycodone. She has long been on a regimen of 150 milligrams of sertraline for depression from her outpatient psychiatrist, which she feels was working well until recent troubles, and says she has been feeling increasingly depressed, having trouble sleeping, loss of appetite with an unintended 15-pound weight loss, and loss of interest and energy in all her activities. She does have a 21-year-old daughter in town, but she feels that she is burdening her daughter, who is trying to go to college, when she talks to her. She explains that she has never attempted suicide before this time, but did so after writing a lengthy suicide note to her daughter because she felt like everything was hopeless. So for this case, what factors make her high risk? How would you talk to her outpatient psychiatrist when trying to plan care outpatient? What factors would influence her being hospitalized or discharged? And how could you help ensure safety when she was discharged? I'll go back to the case. If anyone has any thoughts, feel free to chime in. Otherwise, I'll point out some of the details of this case. So I think some things that make this case interesting is that the patient had acute stressors, like I mentioned here, problems with her husband, now loss of social support, because they recently separated, financial problems, also chronic pain, fell off a ladder requiring 3 surgeries, has her own oxycodone prescription. She's presumably inpatient right now. Given that the average length of stay, in the US for inpatient is 10 days, probably not enough time to taper off oxycodone. That's something you might have to work with her outpatient psychiatrist for, because she already has this prescription for oxycodone, which is legitimate. She just misused it in the attempt. Also, consideration is, does patient have an alcohol use problem? The combination of oxycodone and alcohol with the opioids and the alcohol is at risk for respiratory depression. She's already on a high dose of sertraline, so something to also talk about with the outpatient psychiatrist if you want to continue to titrate to a very high dose, or if we need to augment, because she said that it was working until recently with these psychosocial stressors and worsening depressive symptoms. She does have some social support with a 21-year-old daughter in town, but she feels like she's a burden, and the concern for the preparatory behaviors with writing a suicide note before this happened. So some things to consider before discharging is working with the outpatient psychiatrist, maybe seeing if they have any thoughts on the sertraline, since she said it was working and then it stopped working. Working in terms maybe even with PCP, with the oxycodone. And then I think most importantly from this case to consider is that this patient was doing really well, but had worsening suicidal ideation and attempt with the recent stressors. And so those stressors aren't necessarily going to be something that go away. They're still going to have the debts and the financial troubles and the recent separation even after she discharges. So this was a real case that I made anonymous. And so something that we definitely stressed to the patient was, you know, these stressors are still going to be there when you discharge from the hospital. How are you going to deal with them when you go back and face them? What is going to stop you from making another suicide attempt? And so we made sure that the patient talked to their 21-year-old daughter who expressed their support and that she wasn't a burden, got her in with good therapy so that way she could deal with these financial struggles. And ultimately, after consulting with the outpatient psychiatrist, they went up to 200 milligrams of the sertraline. And the patient said that she did regret what she did. And even though she wrote a preparatory note with the increased social support that we mobilized with her outpatient psychiatrist, she felt like she was safe to discharge. So at this time, there are my references. Any questions? I just wanted to leave time for questions.
Dr. Ty, there's an interesting chat if you want to read it.
Yeah, perceived burdensomeness is a risk factor according to Joyner and the interpersonal theory of suicide. I would want to know how she feels post-attempt given that 70% of first attempters never attempt again. Yeah, I think that's a great point. We had asked her initially, and she, of course, immediately said she wanted to be discharged. It was impulsive. She would never do it again. But me and the attending psychiatrist concerns were this was very prompted by the acute stressors, which were stressors that were still going to be very present when she left the hospital. So just mobilizing that social support to make sure that it wouldn't have a repeat. But I think that is a great thought. Any other questions? Otherwise, I'll turn it over.
So there's a question in the chat. Any tips for incarcerated populations who may be dealing with SIB?
You know, I don't have the most experience with incarcerated populations. I think something just to be mindful of is, you know, the thought of intentional self-injurious behavior for the reasons of wanting to be evaluated in the hospital. That's just something we do have to be mindful of. I had read an article about intentional overdoses in the incarcerated population. And I guess I shouldn't say overdoses, intentional self-ingestions. And they had found that every time it was something like a sharp object, it was an incarcerated population or someone who was very psychotic, something that they knew would be lethal enough that they would get transferred to a hospital and out of the incarcerated environment for a bit. But that's just something I'm reflecting on that I read, but those are just my initial thoughts.
Okay, well, thank you so much, Dr. Ty.
Yep.
I'm going to share the CE link in the chat now for anybody who's interested in a CE or certificate of completion. Be sure just to save okay. And if you have any further questions for Dr. us. And I'll just leave it open for a few more minutes here while people navigate that.